Good morning, everyone. At the outset, I would like to thank the organizing committee, especially Dr. Manoj Mahajan, for giving us this opportunity. So, I thank the chairpersons also. And without wasting time, in the next 10 to 15 minutes, what we are going to discuss is an overview of the breast cancer, especially emphasizing on what are the implications of overtreatment in a patient who has early stage breast cancer, basically when it comes to an Indian perspective. So a brief introduction. In the next 3 or 4 slides, we'll go ahead with the epidemiology of breast cancer, especially in the Indian scenario. So breast cancer is the most frequently diagnosed cancer. It has surpassed CS cervix, especially when it comes to the females. Initially in 1990s, we used to the data said that CS cervix was the most common malignancy diagnosed in females, and after that in 2002 2003 CA breast had surpassed CA cervix, and it is the leading cause of cancer in females. Now globally, breast cancer accounted for 2.08 million out of 18 million new cancer cases, especially in the females. So when it comes to the Indian scenario, breast cancer has surpassed the cancers of the cervix and oral cavity, and it is the most common cancer and the leading cause of cancer deaths in females. In 2018, 1.6 lakh patients of new breast cancer were diagnosed newly, and they represented 27.7% of new cancers in the Indian females and 11% of the cancer deaths. Now, the epidemiology of breast cancer is quite different when it comes to Indian females as compared to the Western population. So, there are few differences which I would like to highlight on. The median age at which we generally see a patient comes with a breast cancer is the peak age is 40 to 50 years in the Indian females, and this is 60 to 70 years in the Western population. And this is of concern, obviously, because we know the earlier the onset, the more aggressive will be the nature. So more aggressive is associated with poor prognosis, and further 60 to 70% of all the patients with breast cancer in the US, they are diagnosed at stage 1, whereas only in 1 to 8% of the Indian female they are diagnosed at stage 1 disease. 10% of the females in US they present with stage 4, and this is in contrast to in India this number is approximately 6 to 24%, with 29 to 52% of the Indian females presenting at stage 3. Although the incidence of breast cancer is rising globally, mortality associated with breast cancer, although it is decreasing in the Western population, but in India it is on the rise. So this is of big concern. Now, when we talk about the subtypes of breast cancer, we all know the breast cancer, we divide on the basis of pathology. The subtyping is on the basis of IHC, ER/PR positivity, HER2 negativity. This classification basically has a prognostic impact. The two most frequent histological subtypes of invasive breast cancer are invasive ductal carcinoma and invasive lobular carcinoma. The other rarer subtypes are very less aggressive. Most of them don't require chemotherapies or adjuvant chemotherapies. 80 to 85% of the cases are invasive ductal carcinomas, whereas 10 to 15% of the cases are lobular in histology. So IHC is important for determining treatment and prognosis of breast cancer. It depends on expression of the biomarkers like ER/PR, estrogen receptors, progesterone receptors, and the HER2 receptors. Now, expression of estrogen receptor or progesterone receptor by more than 1% is basically, we say that these patients tend to respond to hormonal agents. When we talk about triple negative breast cancer is an aggressive form of breast cancer. It is the prevalence of breast cancer in India, triple negative, is 31%, which is much higher as compared to the Western population, where it is estimated to be 12 to 17%. TNM classification is the standard classification that we use for staging of breast cancer. Now, what is the current treatment? What is the guidelines? So, the guidelines, the mainstay of early stage breast cancer, the main treatment that we tell the patient that they should undergo is surgery. Now, surgery can be of various types. We know it can be either we go for complete mastectomy with axillary lymph node dissection or a BCS with axillary lymph node dissection. Adjuvant treatment using pharmacotherapy and radiotherapy is required for treatment of residual micrometastatic disease and reducing the recurrence rate after surgery. So there are guidelines which suggest which patient should undergo adjuvant chemotherapy, which patient should undergo adjuvant radiotherapy. I think there was a good panel discussion on the use of on the chemotherapy adjuvant part and the adjuvant radiotherapy. We'll not go into details of these guidelines. Now, how does prognosis depend on in the patients who have been diagnosed as breast cancer? So basically, when we diagnose a patient of breast cancer, the first and foremost thing that needs to be done is the staging. Staging is very important. 5-year survival rate dramatically declined with higher stages of breast cancer. The 5-year survival rate for stage 4 disease is 22% only, and it is close to 100% for stage 1, 93% for stage 2, and 72% for stage 3. Those patients who have been diagnosed as triple negative breast cancer, they have a higher tendency of recurrence as compared to those patients who have hormone positive disease. And triple negative breast cancer tend to recur early as compared to hormonal positive breast cancers. So ER negative breast cancer have a higher recurrence rate than do ER positive, and the risk seems to equalize between both these subtypes after 15 years of diagnosis. Hormone receptor positive breast cancer, they generally tend to display late recurrences for at least 15 years. Now, lymph node involvement is the most important prognostic factor for recurrences, and axillary lymph node positive disease is associated with a 4 to 8 times higher mortality rate as compared to lymph node negative disease. Approximately, if we talk about as a overall recurrence rates, 11 to 30% of all the patients who have been diagnosed as breast cancer, they develop distant metastasis. So what is the impact of treatment on a patient who has been diagnosed as breast cancer? Why do we need to know what is the treatment, what is the best treatment for a patient of breast cancer? So when we talk about the different treatment aspects, there is surgery, there is radiation, there is chemotherapy. So adverse effects due to surgery, the most common adverse effect due to surgery that a female is concerned about is a cosmetic adverse effect. So which can be addressed by breast conservation surgery and breast reconstruction surgeries. However, this is often associated with poor body image and psychosexual problems. There are a lot of side effects due to chemotherapies which the patients are concerned about, the most important being alopecia, nausea, vomiting, oral and GI mucositis leading to malabsorption, anorexia, weight loss. So these need to be taken into account whether the patient actually needs chemotherapy or not. Adverse effects related to radiation like skin reactions, edema, fibrosis, erythema, changes in pigmentation, ulcerations, these are all needs to be taken into account when it comes to radiation therapy. So even though the drugs are used and other approaches are taken to overcome these adverse effects of cancer chemotherapy, they are often incompletely effective. Treatment of the adverse effects, they also add to the financial burden of the disease. So a patient who has early stage breast cancer, I believe that all the 3 oncologists should come together and decide on whether what is the best treatment protocol that should be followed for such kind of patients. Now, economic impact of breast cancer treatment. Now, breast cancer carries a significant economic burden. Now, adverse economic impact of breast cancer has been reported extensively from various parts of the globe. In 2018, systematic review of 20 studies reported that breast cancer costs increased with a higher stage of cancer at diagnosis. Thus, earlier diagnosis of breast cancer can lower the treatment cost. In 2016, a study from Punjab reported that 36% of the total breast cancer treatment cost was only because of the drugs. So how do we prevent overtreatment? The first approach to prevent an overtreatment is to diagnose a cancer as early as possible. That means we need to have effective screening programs which can diagnose breast cancer in the early stages, which will definitely decrease the cost burden to the patient. Now, by diagnosing breast cancer in earlier stages through the screening of healthy women at a risk, by using modalities such as mammography and ultrasonography, this causes the initiation of early treatment, which can avoid many of the adverse outcomes that are associated with initiating more aggressive treatment strategies at later stages of the disease. However, over-enthusiastic screening can also lead to overdiagnosis. The second approach is to prognosticate the patient and to prevent the recurrences. Now, predicting the recurrence, as we all know, there have been a lot of models which can help us to predict what are the recurrence chances. If this can be achieved reliably, then administration of adjuvant chemotherapy can be limited to only those patients who are at a higher risk of developing such recurrences, thereby avoiding overtreatment in patients who might not need it. The risk assessment tools that are popularly used in India include IHC4, luminal A-B subtyping, then the predict assays. Now, 58% of the Indian oncologists surveyed as part of a recent study reported using online tool predict. It helped them decide which are the patients that can be given adjuvant treatment. So what are the role of prognostic markers? I think in the panel discussion there was a good discussion on which are the assays that are currently recommended. And Malhotra sir brought up a very good point regarding the indigenously developed can-assist breast assay that is slowly coming into picture, and it is a very good tool to decide on what are the patients which actually need chemotherapy when it comes to early stage treatment. So guiding the clinical decision about initiation of adjuvant chemotherapy or endocrine therapy after initial treatment of breast cancer, it depends on the recurrence risk scoring. So these are the various risk scoring assays that are available. As the panel discussion was going on, and they have already discussed, Oncotype DX and MammaPrint are currently the FDA approved methods which are being used, but because of the cost, they are not routinely used. Now, as Malhotra sir said, I think can-assist is a very good tool which we should consider using in our patients. So that we can actually determine which are the patients who need these type of therapies. Now, the use of these prognostic markers can significantly improve the quality of life and therefore cost effectiveness. One more thing that needs to be taken into consideration, the prognostic assays that have been FDA approved or that have been approved by the Western bodies, they lack the ethnical validation. Now, breast cancer is a heterogeneous disease, and global ethnical variations in the outcomes of breast cancer are very well known. Even within the US, ethnic variations are repeatedly observed. Breast cancer incidence is lower, but the outcomes are worst among black women when is compared to white women. Young non-Hispanic black women with breast cancer in the US had significantly higher mortality and morbidity rates than the women of other ethnicities. So this can be because of the variations in the P53 level expression, or can be because of the differences in the mutated proto-onco HRAS gene. Although differences are noticed within the different ethnicities of a single country, it is not surprising to expect major differences with respect to epidemiology and outcomes of breast cancer among patients around the world. So, recent opinions, they strongly advocate that validation of diagnostic and prognostic study findings to suit the population undergoing treatment. There should be the assay that we are basically using should be ethnically validated. The Asian Breast Cancer Cooperative Group 2019, the consensus, it says that evidence-based yet flexible and individualized use of international treatment guidelines, because these guidelines are based on data from predominantly non-Asian postmenopausal women. So none of the popularly used prognostic markers have been ethnically validated in Indian patients, and hence using these markers to make clinical decisions might not be entirely appropriate. So to answer this, we have CAB scoring, that is a can-assist breast scoring, which is an indigenously developed assay. It combines 5 biomarkers: the CD44, ABCC4, ABCC11, N-cadherin, and pan-cadherin. With the help of IHC and with the help of tumor size, tumor grade, and the nodal status, it takes into consideration these all aspects, and it gives a prognostic score. It categorizes the patient into either a low risk or a high risk, and depending on the risk, we can plan whether the patient needs adjuvant chemotherapy or not. So this is one advantage. It's ethnically validated, but the problem with can assist is still not that we don't have a prospective study to decide on how it will do in the next 5 to 7 years. So probably validation through a prospective trial will help us a lot in deciding how where does CAB stands in the prognostic assays. But it has been routinely being used. I think time's up. Just give me 1 minute, please. It has been routinely used. We are using it routinely for those patients who are actually need it. And as I said, the cost is somewhere around 50 to 60,000, much less than the other commonly popularly assays which have been discussed regularly, like Oncotype DX or MammaPrint. I think that's it. Thank you. I thought I'll finish in 10 minutes and we can keep 5 minutes for discussion. Sorry.
Now next speaker is Dr. Manish Gautam. He is a medical oncologist in Kota.
He will speak on efficacy and safety of these immunomodulators in patients with ER/PR receptor positive and HER2 receptor negative metastatic breast cancer in routine clinical practice. So next to Dr. Manish Gautam.
So, good morning everyone. Thanks to Dr. Manoj Mahajan and organizing committee for inviting me in this grand national conference, Transformation of Trend in Indian Perspective. Today we are learning in this ongoing CME about what would we should change in further in our Indian perspective. So today's my topic is the efficacy and safety of palbociclib and ribociclib in patients with estrogen and or progesterone receptor positive, HER2 receptor negative metastatic breast cancer in routine clinical practice. This study has been performed in Tata Memorial Hospital, Mumbai.
I'll just make it full screen.
So the introduction, the treatment of ER/PR positive and HER2 negative metastatic breast cancer has undergone an evolution in the past few years with the introduction of CDK4/6 inhibitors like palbociclib, ribociclib and abemaciclib. These drugs are currently considered standard treatment in the first line and second line setting in the patients with metastatic breast cancers in combination with an aromatase inhibitor and fulvestrant respectively. Although a few studies have analyzed the real world outcome with CDK4/6 inhibitors, such data from India, however, is scant, and authors performed a retrospective analysis to evaluate the efficacy and toxicity of these two available CDK4/6 inhibitors in India, that is palbociclib and ribociclib, in patients with metastatic breast cancer patients treated at a single center in India. Methodology, it was a retrospective analysis of a single center database after obtaining approval of IEC. Patients with histopathologically proven ER and PR positive and HER2 negative breast cancer who had clinical and or radiological evidence of distant metastasis or locally advanced or recurrent breast cancer that was not amenable to curative intent, local therapy like surgery or radiotherapy were included in this study. All patients were treated with palbociclib or ribociclib in combination with any other endocrine therapy partner and could be receiving this therapy in any line of the treatment. Patients could have received any number of lines of prior systemic therapy before starting these CDK4/6 inhibitors, and palbociclib and ribociclib was started in doses of 125 mg and 600 mg per day respectively and was given for 21 days in 28 days cycle. Patients underwent most laboratory tests including CBC and other biochemistries, and also ECG for before starting ribociclib. Radiological assessment was done with CT or PET CT initially, and later every 3 to 6 monthly. This analysis was restricted to patients who started the CDK4/6 inhibitor between January 2016 to June 2019. The efficacy endpoints were progression-free survival and overall survival. Patients who did not experience the events of PFS or OS on this data cutoff date were censored for that, and the most commonly followed RECIST version 1.1 criteria for assessment of progression, and CTCAE version 4.03 classification used for the adverse events happen in this study. Demographic variables used in this and survival outcome like PFS and OS were analyzed by the Kaplan-Meier method and log-rank test, and multivariate Cox regression analysis was performed with inclusion of covariates that significantly impacted outcome in univariate analysis. So this is the baseline clinical characteristic that includes the 57 year was the median age in this study, and most patients were young patients, 45 to 64 year age, that was 68 in number, because total number of patients included in this study were 101 patients. And hematological parameter, median HB was kept 10.8 milligram per DL, and postmenopausal women were 80% and 20% only premenopausal women. ECOG performance status 1 and 2 were most of patients, but also included ECOG performance status 3 or more. Histology, most common histology was invasive ductal carcinoma, but invasive lobular carcinoma were also included in this study. ERPR status positive patients, but low score patients were also low score patients were also included, but in lesser number, and PR low score were 67 patients in this study. Metastatic sites, most of patients were visceral metastatic sites in 88%, but bone only metastasis is only 13% patients. All lines of the first, second, third, fourth, and fifth and sixth lines patients were included, but 22% were in first line, and rest 78% in further lines of the therapy included in this study. Most patients put on palbociclib, and 10 patients in ribociclib group also kept in this study. Any type of endocrine therapy used, but most commonly used was fulvestrant. This is the bar diagram which also showing that only 22% patients used in first line, but remaining were in second, third, fourth, fifth, and also in other lines. The adverse events, most commonly anemia, thrombocytopenia, neutropenia occur in any grade in most of patients showing these, but grade 3-4 toxicity showing by lesser number of patients, and 45% only patients showing neutropenia, and febrile neutropenia shown in only 9% patients. Other common side effects like diarrhea, mucositis, transaminitis also shown, but in grade 3-4 in lesser number. In total patients 101, only 32 patients required dose reduction, mostly palbociclib, because this drug was used in 90 patients, so 125 milligram to 100 milligram in 75% patients, and in another 100 milligram to 75 milligram in 12.5% patients, 125 milligram to 75 milligram in 6% patients, and ribociclib also reduced in only 6% patients. Subsequent treatment required in 77% patient because of progression. The chemotherapy most commonly used in 30 patients, and endocrine therapy in 10 patients. Few patients, 18 patients put on best supportive care, and chemotherapy and endocrine therapy both used in 19% as subsequent therapy. The best response to this CDK4/6 inhibitor treatment was complete response in only one patient, but partial response seen in 52 patients. Stable disease in 19 patients, and disease progression seen in 28 patients. 80 PFS events and 38 deaths occur during this study population. The median PFS in all included patients, those who received CDK4/6 inhibitor in first line setting, and in those who received in second line or later line settings, were 7.7 months versus 21.1 month and 5.98 months respectively. Same median OS in all included patients, those who received CDK4/6 inhibitor in first line setting and those who received it in second or later line settings, were 27.1 months versus not achieved and 20.2 months respectively. So this overall study population at 1 year, 2 year and 3 years, the overall survival were 73.8% versus 55.2% and 42.7% respectively. So we performed a subgroup analysis based on endocrine sensitivity. There was no difference in median PFS between endocrine sensitive and resistant patients. This is the chart which showing that in first line huge difference than while using these drugs in second or later lines. This is the overall survival, also showing same, not reached in first line while using in first line, and lesser median overall survival in while using in second or later line therapy. So this is the multivariate analysis for the PFS. In the PFS analysis, first line setting and ECOG performance status 1 was significantly associated with better outcomes. Same as in multivariate analysis for overall survival. In the overall survival analysis, only ECOG PS1 was significantly associated with the better outcome. So comes to the discussion. After accounting for differences in patients' characteristics, the efficacy and toxicity results of CDK4/6 inhibitor treatment in routine clinical practice are similar to those reported in the pivotal clinical trials. Results are important because the data set includes patients who are often excluded from the clinical trials. So poor performance status and heavily pretreated status and extensive visceral diseases having poorer outcomes. The median PFS and OS in our patients population in first line, that was 21.1 month and not reached respectively, and second or later line 5.98 month and 20.2 month respectively. So these study population was comprised to heavily pretreated metastatic patients in this study, and 53% patients having 2 or more prior lines of endocrine therapy and or chemotherapy, in contrast to Paloma 2 trial, which included patients without any prior systemic therapy for metastatic disease, and Paloma 3 trial, wherein 46% patients had received 1 or prior endocrine therapy, while none had received any prior chemotherapy. An overwhelming majority of our patients had visceral metastasis, that is 88%, and only 13% patients having bone only disease, in comparison to Paloma 2 study, where 23% having bone only metastasis disease. 56% of our patients were in ECOG performances 2 or 3, it means poorer performance status, in contrast to none in Paloma 3 study. So these considerations suggest that study population had poorer prognostic characteristics in comparison to pivotal trials. So, as expected, analysis suggests that patients who had better performance status were less heavily pretreated and better outcomes compared with those who with the poorer performance status and more heavy prior treatment. So, palbociclib was well tolerated in the 125 milligram dose with only 32 patients required dose reduction compared with 36% in Paloma 2 and 34% in Paloma 3 trial. The proportion of the grade 3-4 neutropenia was 45%, which is lesser in compared to Paloma 1, where the grade 3-4 neutropenia was 62% and 66% in Paloma 2 and 65% in Paloma 3. Febrile neutropenia is also only shown 9% patients in 9% patients where antibiotic use required. Toxicity or intolerance required treatment discontinuation was also only 3% in this study in comparison to Paloma 3 where 4% was discontinued due to toxicity and in 4% in Mona Lisa 7 also discontinued due to toxicity. So, this study is unique in some aspects. Patient population was heavily pretreated in this study. 80% patients having received CDK4/6 inhibitor in 2 second or later lines and 50% patients in the third or later line of treatment. And also having poorer prognostic factors because 87% patients having visceral disease and 56% patient having echo performance status 2 or more. So, this is different patient profile, different patient profile that included in this pivotal trial, and yet treatment was reasonably well tolerated with only 3% patient with discontinuation of this therapy due to toxicity. Okay, just coming to point. Only a small fraction, 20% patients received CDK4/6 inhibitor in first line treatment. This study also having some limitations that because it's a retrospective nature, relatively small sample size and potential biases in patient selection as well as heterogeneous patient population. So, in conclusion, palbociclib and ribociclib are well tolerated when used in routine clinical practice in Indian patient population also, and result in survival outcomes in first or subsequent lines of treatment that are concordant with those reported in pivotal clinical trials. And results also suggest that poorer performance status at the time of initiating CDK4/6 inhibitor therapy is associated with worse overall survival and not the number of previous lines of the treatment. Thank you.
Thank you, Dr. Manish Gautam, for such nice academic event. Now, I would like to invite our next speaker, Dr. Sachin Jain. Dr. Sachin Jain is Senior Medical Oncologist in Udaipur, and he will talk about the systemic review and meta-analysis of prevalence of TNBC in Indian perspective. Dr. Sachin Jain.
Can you share where is the slide?
We will conduct question answer session in last of these all sessions after the panel discussion.
Good morning, everyone. I would like to thank organizing committee and especially Dr. Manoj Mahajan for inviting me. And thank you very much, Chairperson, for nice introduction. So, in the continuation of trends in the so in the continuation of the in the trends of transformation, basically in the Indian perspective, the triple negative breast cancer, as Dr. Ankit already told, it's more common as compared to the Western world. So I will present one study which is giving ideas about the prevalence of this triple negative breast cancer in India. So what is triple negative breast cancer? As we all know, it is the ER receptor negative, PR negative and HER2 negative by IHC, and it accounts for 12 to 17% of the breast carcinoma in the Western population, and significantly more aggressive than other molecular subtypes of breast cancer. Majority are of grade 3 tumors and most frequently high grade invasive ductal carcinoma of no special type. For the triple negative breast cancer, we can see in the right side graph, the distance recurrence in the triple negative breast cancer in the first 3 years is very high, but after 4 to 5 years it's dropped down and remain low even after the 10 year. While in the other subtypes like ER/PR positive or HER2 positive, the risk of disease recurrence remains low even after the 2 to 3 years even, but it remains stable even after the 10 year. So chances of recurrence in the first 3 years are more in TNBC, and after that it suddenly decreases. So it is a triple negative paradox. It is aggressive, but chances of recurrence after 5 years are less. In the left side, the relapse pattern of the triple negative breast cancer, these has short disease free intervals, increase in the visceral mets, and chances of CNS metastasis are more as compared to other subtypes. So I will explain about the prevalence of triple negative breast cancer in India, a systematic review and meta-analysis. It was published in 2016 in the JGO in the ASCO journal. In the introduction part of this, the breast cancer is a heterogeneous disease with different biological subtypes that are recognized by gene expression profiling studies. And triple negative breast cancer, as we have discussed, is the ER negative, PR negative and HER2 negative. And 12 to 17% of breast cancer are triple negative in the Western population, occurs more frequently in younger women and associated with higher histologic grade and more advanced disease. Same in the India, what we are seeing, the breast cancer is nowadays most common cancer in India. As Dr. Ankit told, it surpasses the cervix cancer and nowadays is the #1 female cancer in India. In 2012, it is estimated that approximately 1,45,000 new patients were diagnosed with breast cancer in India, and nearly 70,000 women died of the disease. And in 2020, 2 lakh new cases were diagnosed and 76,000 women died because of the breast cancer. The age standardized 5-year breast cancer survival for Indian women diagnosed with breast cancer is 60% compared with the 80% in the Western countries. Whereas breast cancer incidence seems to be increasing in the country, the epidemiology of the disease is still inadequately studied. And the prevalence of triple negative breast cancer in India is reported to be higher than that observed in the Western population. And this study has tried to prove this. In the aims of this study, it was the prevalence rate of triple negative breast cancer in India. In the methods and material, they have used different studies that reported on the prevalence of triple negative breast cancer in India that were published between the January 1999 to December 2015 and were identified by using Medline, Scopus, Embase and Web of Science databases. The eligibility criteria for this meta-analysis was only those studies were included in the meta-analysis which provided data on patients with breast cancer in India and described prevalence of triple negative tumor subtypes in the study population. Studies reporting on all three receptors, that is the ER, PR and HER2, or those that reported on the proportion of the TNBC were included. And all the inflammatory breast cancer were excluded from the study. So with the their inclusion and exclusion criteria, the records identified by database research is 242 studies they have identified. Out of that, some duplicate studies were removed, and at the end 129 studies were then found. Then after the inclusion and exclusion criteria, only 17 studies were remained to study. And in these 17 cross-sectional studies, they have included 7,237 patients, and their characteristics were mean age of patient is 43 to 55 years, and it is weighted average of 50 years. Premenopausal patients were 27% to 67%, and weighted average of 41%. Patients with grade 3 disease are 16 to 75% with weighted average of 57%. Patients with tumor size more than 5 centimeters were 3% to 65% with the average of 24%, and patients with positive axillary lymph nodes were 3 to 90% and with the average 57%. So we can see that in India the mean is 50 years. Premenopausal patients are more affected, and patients are present with more aggressive disease with tumor size more than 5 centimeter, and in the majority of the patient the lymph nodes are positive. So in the result of this study, the prevalence of triple negative breast cancer was 31%, ranges from 27% to 35%, and there are substantial heterogeneity across the studies, but they are made by the pooled estimated from the fixed effect model meta-analysis, and it was comparable. The other subtypes like HER2 hormone receptor positive are 48%, and HER2 positive breast cancer are 27% in this study. And the prevalence of TNBC by study level characteristics, they have also taken 4 studies from each region, like from the east, from the west, north and south, and found that the prevalence of triple negative breast cancer all over India is remains same, that is from 28% to 34%. And according to the studies, they have also defined receptor status according to their criteria, and 9 studies defined hormone receptor positive as ER and PR more than 1%, and 4 studies defined hormone receptor positive as ER PR more than 10%, whereas 4 studies did not describe the definition of hormone receptor, but they have mentioned in their studies. 9 studies defined HER2 positive status as only 3+ by IHC, and 5 studies included 2+ as positive, whereas 3 studies did not describe the definition of HER2 receptor. According to that, also no significant difference in pooled estimate subgroup by different definition of hormone receptor and HER2 receptor was found. So in the discussion, prevalence of triple negative breast cancer in India ranged from 27 to 35% across all the studies, with a summary of 37%. This is comparable to the prevalence seen in the African American woman and is more than twice the rate in the white woman. A higher prevalence of premenopausal breast cancer, grade 3 disease, the larger tumor size, and all of which are associated with triple negative breast cancer were also seen in Indian scenario. The multiple factors may account for higher prevalence of triple negative breast cancer in India are early age of onset of breast cancer. Because of our age pyramid of India is heavy at bottom, so majority of the population is of children and young adults. The lifestyle factors such as diet and obesity, reproductive factors such as multiparity, socio-economic status, screening behavior, and potential genetic susceptibility of Indians to triple negative breast cancer. So in the conclusion, the high prevalence rate of triple negative breast cancer is found in India, that is 31% as compared to the 12 to 17%, and further research is warranted to identify the determinants of such a high prevalence of TNBC, as they may have implication for addressing the burden of the breast cancer mortality in India. Thank you. Thank you.
Thank you, Dr. Sachin Jain. Now we are open for any question from audience related to last 3 talks. Thank you, Dr. Sachin. Now, our next section is panel discussion about the benefits of neoadjuvant chemotherapy.
Uh, I think I'll take opportunity to invite our local oncologists, surgical, medical, radiation oncologists, that we should collect our data and let's see how our population is behaving. Because to my experience, it is changing very fast. Before 2015, trends were different. After 2015, trends are changing in local population I'm talking about. When I published one paper in 2016 or 15, the incidence of TNBC was approximately 21%. Now it is 27%. So I'm sure things are changing. Age pattern is also changing. We used to see much younger patient below 35 earlier. Now they are almost equal in 40, 60, and beyond 60. So I think it will be a nice idea. We can all collect our data and have a demographic presentation in one of the conferences.
Ma'am, even today we are planning to meet of the conference for the collaboration. So
sure.
I'll be
welcome.
Yes.
Welcome proposition. Thanks.
Now for next session, panel discussion. Panelists, they are Dr. Preeti Agarwal, Dr. Mamta Loda, Dr. Devendra Jain, Dr. Mukesh Chaudhary, Dr. Gaurav Adavan, Dr. Darpan Dadij, and Mukta Sukhadia. Welcome and conduct the panel discussion.
Yeah, good morning, everyone. First of all, I would like to thanks to Dr. Mahajan for arranging such a nice CME. I really enjoyed today's yoga session with early morning at the Fateh Sagar Lake. So the beginning of the day is really wonderful. Now, the job was given to me to conduct a panel on the advanced breast cancer, the really benefit of the neoadjuvant treatment, actually. So to give overview of this panel, we have an eminent panelist. We have a good team of surgical oncologists, radiation oncologists, as well as general surgeons. Usually, most of the patients, they usually consider the general surgeon first, and then they refer to the oncologist. So we have a Dr. Gaurav, Dr. Darpan, and Dr. Mukta is general surgeons, and we have a surgical oncologist, Dr. Devendra Jain and Dr. Mukesh Chaudhary. I hope Dr. Preeti and Dr. Mamta is there. Yeah. Okay. So everybody is here, right? So let me begin with a very general discussion. It's a 55-year female patient. She presented with a history of left breast lump, which is left upper outer quadrant around 6 into 6 centimeter with the skin infiltration. And clinically, she also have a left axillary lymph node, which is palpable as small node at level 2. And no major comorbid conditions except for hypertension, which is very well controlled with antihypertensive, and there is no family history. And we have this information like the clinically it is T3N1 and with biopsy, of course, biopsy suggestive of IDC. So with this brief history, I think I would start with the discussion with our general surgeon. Whenever such kind of the patient, they present the OPD, if this clinical palpable lump, which is little advanced, is around 6 into 6 centimeter with the skin involvement, how they proceed? I think we start with the discussion with Dr. Gaurav.
Thank you. Basically, because she is of 55 years of age and she has a big lump around 6 into 6 centimeters with skin infiltration, and also there are some axillary lymph nodes, and she is hypertensive. We would first downstage the tumor size so that we are able to go for the excision of the lump. If we can save the we can go for breast conservative surgery, but if not possible, then we can go for mastectomy too. So I would recommend her to go for a neoadjuvant chemotherapy first, and then later on she can downgrade her size of the lump as well as the infiltration and the lymph nodes. Then we can assess her again after the neoadjuvant therapy that how she has behaved to that particular neoadjuvant chemotherapy. And if she does good, then we can timely go for the surgical excision, depending whether it can be a breast conservative surgery or it can be a mastectomy too.
Okay, so that is more towards the treatment part. I think that we are taking opinion of other surgeons, Dr. Darpan and Dr. Mukta. Your
Dr.
opinion?
Ashish, here, can I
Yeah.
make a small comment?
Yeah.
Would this be clinical T3 or T4 if you have skin involvement?
It's a direct involvement.
So T3
It's a,
or not T4?
It's not T4.
Okay.
It looks like a T3 only. It's a deep. It's not classical ulceration. Dr. Darpan is there?
Yes, sir. I mean,
Yeah.
yeah, I agree with Dr. Gaurav, sir. I will.
So
plan-
I think we can look for the treatment, but later on I think this is the point which I need to discuss here in this slide. Okay, so let me discuss with the investigation part first, and we'll proceed for further. So Dr. Darpan, I'm asking like if the patient is presented with such of the clinical symptoms and your examination suggests of little bit advanced, it's not early stage. So how do you investigate in terms of your workup?
Definitely, we will start with triple assessment, clinical and radiological and histopathological. In clinically, we examine the patient. After that, mammography is advised to the patient, and coroneal biopsy should be performed. Along with coroneal biopsy, histopathology and ERPR, HER2 positive status will be assessed. As per report, we will proceed further.
Okay. Dr. Mukta? She's not here. Okay. So let me take the opinion of our surgical colleague, Dr. Devendra. Do you agree this mammography is suffice your workup for as a part of the radiological workup in such a patient who present with a little bit advanced?
In this patient, it is locally advanced breast cancer.
Right.
Apart from mammography, if the facility is available, the best thing to go for PET CT scan to actually stage the disease. And if the PET CT is not there, then CCT thorax, ultrasound abdomen and bone scan. They should be done to rule out any metastatic disease. If there is no metastasis on these imaging studies, and if possible, it is better to do an axillary lymph node site FNSE to see whether the lymph node is actually involved or not. Lot many of the times, few enlarged node may be benign also. So these three things are important, and in biopsy, it is very, very important to check for ERPR and HER2 new status. After checking all these things, then we should formulate a treatment plan for this patient.
Okay. There's one point which Dr. Gaurav mentioned regarding the excision biopsy. Do you consider is there any role in this patient?
No, if true cut biopsy is possible, then there is no use
So
of
this
doing
patient
a
already true cut biopsy is IDC. So I think excision biopsy is not playing much role, and this is advanced. I think Dr. Mukesh, your take on regarding the workup. Do you suffice like the PET scan is must for all patient, or CT scan is fair enough in patient of little bit advanced cancer, or what is your role of the doing MRI breast in this patient?
First, PET if available, it's best. If not available, we can go for a CT thorax, abdomen, pelvis with bone scan.
Okay.
As previously PET was not available, the investigation was CT and bone scan. And MRI breast for this patient is not much role. If patient is willing for breast conservation, then we can go for MRI.
Why I'm keeping this point of breast MRI if we are looking for a conservation later on to see any skip lesion? So do you feel knowing this skip lesion, because if you start with some kind of neoadjuvant treatment, probably you can miss that lesion in the later on. You probably, so if your plan is a conservation, probably
then
they have some role. Yeah.
This is one thing, most of the places this breast MRI is not available.
Yeah.
There are very few places in India where the breast MRI is there.
Yeah. So that's a technical
and if
challenge.
If we are doing a PET CT scan, lot many of the times they can also pick up any metabolic activity in any other quadrant of the breast. That can give us a fair indication about the multicentricity or multifocality of the disease.
Okay, great. Very important point which you mentioned, Dr. Devendra, FNSA of axillary node. So I need to take this opinion for Dr. Mamta. So, do you do routine address the axilla, especially cytology or biopsy confirmation if the patient is already having the core biopsy, or is there anything is helpful in your decision making later on as far as the radiation plan is concerned?
If it's already an advanced cancer malignancy and the primary site has been proved, but regarding the axillary site, if we can start with USG axilla, that would be great. We can have some insight on the nodal involvement, but then PET scan, if it is being done, then it can very well show the presence of lymph nodes. As of now, yes, axillary lymph node positivity plays very important role for the if neoadjuvant chemotherapy has been given, and if there is a very good response, then we have to plan the radiation accordingly.
So if the patient having a PET positive axillary lymph node, you won't consider any cytology or biopsy confirmation of axilla, or does it play any role in the future treatment?
No, if PET scan is confirming, it's okay.
Okay, so let me take our opinion of the medical oncologist, Dr. Preeti.
Yes. Even if PET is positive, if clinically it is hard node, large node, I will not consider FNA of that node. If it looks clinically positive.
So the why keeping this point is important, because right now there is one study called as Monarch E study, where there is a, I think the data is recently published in the ESMO and ESCO also. The patient who is having locally advanced breast cancer patient who receive a neoadjuvant treatment, and actually they, for the eligibility of the adjuvant abemaciclib, I think they have a very fixed criteria, and if suppose your clinical size is more but a radiological size is less than 5 centimeter if the tumor is not high grade, and I think that case they require a minimal criteria of cytology or biopsy confirmation of axilla. So being as an investigator of this study, I found some challenge in some of the patients, because we found clinically patient tumor size more than 5 centimeter, radiologically it is 4.5 centimeter, and you give the neoadjuvant treatment, and the patient is not, because for eligibility of that study of adjuvant abema, you have to be either grade 3 tumor or it's a cytology or biopsy confirmation of that. Because if after neoadjuvant the node is negative, the patient cannot be give the benefit of that adjuvant treatment. So this is important. Any other investigation, Dr. Preeti?
IHC has to be done before deciding any neoadjuvant. IHC, ERPR, HER2 is the must investigation.
So let me begin with that same thing, ERPR, HER2. So you do ERPR, HER2 in all patients before starting neoadjuvant treatment?
Yes.
Okay. So how you decide your treatment of the neoadjuvant? So anybody is been, and as per the surgeon in general surgical side, do you want to give the upfront surgery in this patient? Anybody is and disagree of the neoadjuvant? So everybody is agree for neoadjuvant? Okay, so Dr. Preeti, neoadjuvant.
But few things I would like to highlight in this patient. We should discuss with the patient beforehand, before starting neoadjuvant chemotherapy, whether the patient wants breast conservation therapy or MRM. Because if the patient wants breast conservation therapy, then it is very, very important to put some clips and or markers near the tumor, so that if the patient has got a very good response to chemotherapy, then we know the area which needs to be taken out. Because many of the times we face this challenge. Patient going for neoadjuvant chemotherapy, then coming back to us and asking for a breast conservation surgery. But we don't know what was the area. So this is very, very important before considering neoadjuvant chemotherapy.
Taking this point forward, Dr. Devan, how many clips do you advise? Like, there are people who put it in the center, there are people who put it in the two-dimensional area. How do you, what is your policy?
It should be, one should be put in the center and few in the periphery of the tumor, so that we know what, actually we have to take out the tumor along with a margin. So apart from the tumor, the periphery of the tumor should be marked nicely.
Means you want to remove the whole part which was initially there.
Yes, because with neoadjuvant chemotherapy, the response can be of two types. Either it is centripetal or centrifugal. So sometimes what happens, the tumor shrinks centripetally. But sometimes what happens, the tumor shrinks, but few of the tumor cells are here and there. So we need to take out that area completely, because we don't know what kind of response.
Everyone agrees to it?
So Ashish, can I make a comment?
Yes,
I think one very, very important take-home message at this point of time in your discussion should be that every single patient of coming like this and also early breast cancer should be discussed in a multidisciplinary way. So the day and the time and the era when if the patient first went to a surgeon, surgery was done. If the patient went to a medical oncologist, chemotherapy was done. That is over. So every single patient should be evaluated in a multidisciplinary
that's why, sir, I start
way.
my sentences. Everybody is the surgeon, radiation oncologist, is medical oncologist, agree this patient is for neoadjuvant treatment, right? Now, one important thing which was Dr. David was mentioning regarding the putting the clip and to counsel the patient, to discuss with the patient preference. I think most of the time we see the patient actually rely the treating doctor. I do agree some of the patient they have a preference, but most of the time actually the breast conservation is the own advantage, and we always facilitate breast conservation whenever it is feasible we do. So those scenarios where the patient is actually asking, most of the time they are actually asking the treatment. And I think that there is some philosophy in some of the patients the surgery, mastectomy, removal of the organ is give the more survival advantage, and that is very common in the periphery. So that's why I think we should facilitate breast conservation whenever it's feasible. There is no, unless there is any contraindication. Regarding the clips, I think one limitations, I think Dr. Mukesh, would you agree, whether it is available every places where you put a clips, what do you do in Palanpur? So anything to overcome that?
Yeah,
if
I'll tell you one very simple technique.
Yeah, Mike.
If you don't have the that gun by which you can mark the area, what you can do is that you can take a wide bore spinal needle, and in that spinal needle you can put in a very fine wires, cut small pieces. Then you can put in the area and you can put those clips near the tumor. This is a very simple technique to mark the tumor site, which we don't have a biopsy gun. Sometimes if we need to do it, we do it this way.
Yeah, so that you can just find out what is the if the patient achieve a complete clinical response, I think that's where you can reach, and you can take a margin and you can cut it out later on. That's I would agree. So Dr. Preeti, now following your quotes, so the patient is referred to for neoadjuvant treatment. All surgeons are agree. This patient is not for friend surgery. Patients is relying on the treating doctor. Whatever the best treatment you can offer, please go ahead.
So we need to know the ERPR HER2 status, whether the patient is HER2 positive or HER2 negative. If HER2 negative, then I'll start with anthracyclines. And after 4 cycles of anthracycline, if good response, then I'll complete the neoadjuvant therapy with 4 more cycles of taxanes and then refer back to surgery. If HER2 positive, then I would like to start with HER2 therapy along with taxanes, and then probably later on anthracyclines, and then refer to surgery.
Okay. So let me start with Dr. Mukesh.
And if triple negative, Preeti, what would you do?
Anthracyclines and taxanes.
No platinums?
No platinums as of now.
Okay, so let me start with the surgeons. Dr. Mukesh, this patient is suppose ERPR is positive and HER2 is negative. What is your possibility of this patient response with a neoadjuvant treatment, and you can facilitate breast conservation?
With ERPR positive, the response will be not as good as TNBC.
Absolutely. So do you still, this patient is operable patient, and you can very well do the operation if the patient is not a candidate for.
If patient is ERPR positive and HER2 negative, then we can discuss with patient. I will prefer chemotherapy, but if patient not agree, then we can go for a surgery in ERPR
so
positive.
even in ERPR positive, you will definitely refer here. Dr. Darshan, you will also agree with this statement?
So in this patient, suppose straight away, my first opinion will be neoadjuvant chemotherapy, irrespective of the status of ERPR HER2 neo. Because by sending the patient for neoadjuvant chemotherapy, we can have one very important benefit to check for the response, whether the patient is responding to that particular chemotherapeutic agent or not. Suppose if the patient is not at all willing for neoadjuvant chemotherapy, and if he wants and insists for surgery, then after taking a proper recording of that in my notes, that we have advised this, but patient wants this. So we can go for straight away modified radical mastectomy if the metastatic workup is negative.
No, so patient is your patient. Patient wants the best treatment. The patient will ask, what is the intent and what is the goal of my therapy? So intent of the new NSCT and what is your goal?
The intent is to control the circulating.
Because if the patient is ERPR positive, I think as for the available literature, the patient having achieved a path CR is likely it is around 10 to 15% if the patient. If the patient is triple negative and HER2 positive, that's a different story.
No, in that, what my idea is to give neoadjuvant chemotherapy, especially even if the patient is ER/PR positive and HER2 negative, is to check for the response of the chemotherapeutic agent. Because many of the times we have seen that patient receiving 2 cycles of neoadjuvant chemotherapy and there is no response. Then we know even if we give this chemotherapy, it will not be of any use. Then what we can do is that we can operate the patient. If the patient is operable, then we can change the regimen.
Okay.
So my idea for this patient is, first my advice will be neoadjuvant chemotherapy.
Okay, so all the surgeons agree neoadjuvant irrespective of ERP or HER2
I would see the response of the, as Dr. Devendra mentioned, that we start with the neoadjuvant chemotherapy, and if we are not getting the response, then we should switch over to neoadjuvant endocrine therapy rather than, because she is a 55 years old lady, and if that responds to that, then we can go follow it by surgery after that. Not necessary that we should stick to neoadjuvant chemotherapy in that case.
I think Dr.
Ashish,
Preeti, yeah.
I just like to ask the panelists, what is the role, what do they believe in IHC4? IHC4 is IHC3, so do they use Ki67? What do they use in this case? And do they do an interim evaluation after the mastectomy specimen? Do they do a Ki67 on that?
I think I would ask this question to Dr. Preeti, but to add one more thing, which what sir is mentioning, if the chemotherapy is not responding, he wants to switch to the hormone therapy. I think Dr. Preeti, just to add my point, this is a sequential treatment. So 4 anthracycline you usually consider, and after that the sequential taxane. So if your anthracycline not responding, you can't leave the patient, probably you're shifting to taxane. So to add to these 2 things, one is the IC4 as well as the switching to other agent versus endocrine.
Switching, if I see if patient is not responding to anthracycline and the patient is operable, I would definitely send the patient.
Patient is operable since day 1, we know.
If patient is not
we are
responding
for
to anthracycline and the patient is still operable, the disease is progressing, I would definitely send the patient for surgery. I will not give second line taxanes. I will not wait for taxanes. I will send for surgery. And what the other question?
For ISC4, you look for a Ki67 of deciding your treatment?
No, as of now, no. Yes, but Ki67 will help. High Ki67, higher chances of responding to chemotherapy.
So, yeah, so there is a lot of studies saying the response of chemotherapy based on the Ki67 high is probably there is a more chance of response. Suppose this patient is not responding, as you are mentioning in some patient, 4 cycles. Dr. Mamta, your take on that. Is there any role of radiation if the patient is not responding to neoadjuvant and still the patient is inoperable or those scenario?
If the patient is still inoperable, we can go ahead. We can think of giving radiation therapy in neoadjuvant settings also. But as of now, there are no clear-cut indications also. But till the patient is operable, we should go for surgery.
So what I understand, which Dr. Mamta has rightly mentioned, if the patient is operable, there is no much role of radiation. But if the patient is inoperable, not in this case, where there is a role of radiation to convert inoperable disease to operable lesion. Anthracycline followed by changing the hormone therapy. I think taxane should be offered, which I believe most of the medical oncology do that, unless until the patient is not responding. If there is a patient is operable, I think we should go ahead with the surgery. Dr. Preeti, number of the cycles and regimen which you give. What kind of the regimen you follow?
Anthracycline, taxanes, total neoadjuvant therapy, 4 AC, 4 packing.
Is there any role? It's a dose dense schedule or in
yeah, dose dense usually.
Okay. One thing I was mentioned in the workup, genetic testing. So do you consider genetic testing at the beginning, or you wait for ERP or HER2 and you decide
after
anything?
ERP
What is your criteria of getting a genetic testing done in your breast cancer patient?
HER2 new patients.
HER2 new?
Negative.
Negative patient, right?
Yes, HER2 new negative patients, TNBC or ERPR positive patients, especially young patients having family history.
So what's the definition of young?
Young patient less than 40 years of age.
Less than 40. Okay. So if the patient is 55 year triple negative?
Yeah, I would still advise. I would say especially.
So data is basically less than 60, which I believe. So we have already discussed interim evaluation. If the patient not responding, I think we can go to the surgery or changing the regimen. Now, to the surgeons, Dr. Mukesh, do you feel this neoadjuvant treatment helps in the surgical benefit in terms of, it's only purely surgical benefit, or is there any benefit in the survival of the patient also? You refer the patient to medical oncologist. What is your goal? Is it only surgery, or is there any benefit in the survival?
First goal is to see the response. Second is
because as I think we are discussing, Dr. Garima is also mentioning, you remove the entire cavity. I think Dr. Devendra, you are mentioning. Yes. You put a clip and you remove the entire tutor at the baseline. I think there was a debate in that part, because the intention of the neoadjuvant treatment is the downstage the disease, and probably you can facilitate breast conservation. So, but that is your goal, or you are looking for any other benefit? Is there any benefit of neoadjuvant chemotherapy on the survival? If the patient achieves PET CR,
then it has.
So, do you feel in ERP or HER2 positive patient, as I mentioned, that the PET CR rate is just 10 to 15%. But if you see the outcome of this patient, it's much better than any other subtype. Now, luminal A versus luminal B. So, luminal B having a more PET CR, but the outcome is poor compared to luminal A. So, does you keep these things in your mind when you prescribe a neoadjuvant treatment and decide your regimen or your plan of treatment?
Yes.
Okay. Dr. Preeti, any role of immunotherapy if the patient is ERP or HER2 negative, triple negative, suppose?
Yeah, there are, if PD-L1 positive, yes, there is data, but I've still not used it.
You have not used one. Okay. So, as I understand, this patient, which is advanced breast cancer and will require a neoadjuvant treatment, all patients should go ERP or HER2 testing, and whenever it's feasible, if the patient is eligible for genetic testing, we should offer, because there's a lot of data is coming for treatment, modification based on the genetic, or if the patient is BRCA positive patient, there is a data of immunotherapy also, especially in triple negative patient. How much time I have left? Can I go for a short, quick, another case? Okay. So this is a young woman, T2 and 2 triple negative breast cancer. Metastatic workup is negative. Additional workup, Dr. Gaurav, you can take this.
I think that she has multiple lymph nodes present in the axilla. So
yes,
we have already talked that we should go for FNEC or core biopsy of the lymph nodes. But the thing is that she is triple negative, then grade 3 tumor. Again, we are planning for a new conjoint therapy, and this there is a debate that whether we should go for a sentinel lymph node biopsy before giving the therapy, or we are going to go for the.
This is N2 disease.
Yeah, but it is triple negative, and there are multiple lymph nodes, and the lymph nodes biopsy, if it comes out to be positive, then we can also go for neoadjuvant therapy in this case too.
Okay.
And sentinel lymph node biopsy, if it has to be planned before the therapy or not, that is a debatable thing. After giving neoadjuvant, we can go for that. And putting the clips, which Dr. Devendra spoke, was you can even put the clips in the axilla too before starting the therapy.
Okay, great point. So, Dr. Darpan, your take on that, especially on the sentinel node. Do you consider sentinel node in this patient at this beginning?
No, sir.
No. Suppose if the patient achieve complete axillary negative post NSCT, do you consider sentinel at the moment?
Yes, then
yes. So that's the data. So additional workup. Yeah, just 1 minute. Okay. So I think this patient is BRCA positive. So Dr. Preeti, neoadjuvant treatment, everybody's agree.
Yes.
What regimen and would be the best for this patient?
So BRCA positive, carboplatin, of course, increases PET CR rates. I would like to add carboplatin to neoadjuvant therapy as well, and then depending on PET CR achieved or not achieved, and then if PET CR achieved, then observation not achieved, Olympia trial, olaparib maintenance.
Yeah, so
ideal
that's
situation.
Yeah, so that's the one thing, and there is also data of using immunotherapy, pembrolizumab, carboplatin, paclitaxel in a patient of triple negative breast cancer patient. And last comment from the surgical side, I think Dr. Devan, you can take your surgery. If the patient already is a BRCA positive patient, and the patient has achieved a very good response, clinical CR, what is your surgical plan?
Already we have discussed in the morning about that. My surgical plan will be bilateral mastectomy and bilateral salpingopterectomy for this patient.
Okay. Any other
With
difference?
reconstruction of bilateral breast.
Okay. Thank you. Ciao. Thank you. Thank you. Thanks to all the panelists for the participation.
Okay, on behalf of chairpersons, I thank you all for nice presentation, very fruitful and practical discussion. Thank you very much.